select 8 districts where we are going to carry out our intervention, where we are going to intervene. Intervention, we shall explain intervention which involves those tools, X-ray, artificial intelligence, things like that. And we said before we shall not intervene. The 4 districts remain doing things the way they were doing, and we shall just compare with them in the 8 districts. In order to make that, we are going to be based here for 4 months in the community. But not only 4 months, we shall go away. The total time we shall be based in those communities will be 12 months. So we shall go away and then come back another 4 months and stay in the community for another 4 months. Again, that time. So even when we are staying at the clinic, we shall stay 4 months, come back another 4 months, and that. So for each of those, we shall stay for a total of 12 months continuously if you look at them. But they will be interspersed with 4 months in the clinic. And so once they selected, then we were selected that we come here starting February. That was their choice from the decision we came up. We started in Kasanga. In June last year, we started in Kasanga and in Nakaseke Hospital. Kasanga was doing the hotspot, which we are going to be doing here. And Nakaseke was doing the clinic based. We were based at Nakaseke Hospital for 4 months from June to the end of September. As September came in, at the end when we were leaving Kasanga, unfortunately, there is fortunate and unfortunate, Ebola hit, and Kasanga was closed in October, when we had just left end of September. And we went to Bujiri and Iganga. Our teams right now are based in Bujiri and Iganga. And in Iganga they are the hospital, and in the Bujiri there in the community. And this coming month, we are going back to Kasanga because we left 4 months. We are lucky that the Ebola ended. Now we can go back to Kasanga. So we were at Kasanga this week, last week. So we are going to be in Kasanga again after those 4 months at the clinic for another 4 months. And we were yesterday in Nakaseke. Nakaseke, we are also going to be doing what we are going to do here. We are now in Nakaseke. We are now going to the community. The other time we went to the clinic for 4 months, and we went out for 4 months. Now we are in the community. Yesterday we were introducing this to the LC5, to the district officials of Nakaseke Hospital as well. And also, so we are now going to be in 4 districts. We are going to be in Kasanga, Nakaseke, Buikwe, and Kayunga. Kayunga is also going to be based at the clinic. So Kayunga to the clinic, and Kasanga in Buikwe, and in Nakaseke we are going to be based in the community. So after that, we shall go to the other 4 and get out like that. So I'm going to take you through how we ended up. That's how we ended up selecting when to come here and others. So it was the process where the teams participated, and I'm just going to explain to you how all that process was. Going back, a small background. Unfortunately, yeah, it may not be very clear, but yeah, I think I listen. So I'll just say that we all know, and many of you have worked in TB. TB is a major burden globally, not only in Uganda only. But it's a disease which is curable and can also be prevented. However, every year it is estimated globally that there are about 10 million people who develop this disease. But among those who develop the 10 million, we only identify 7 million. The rest remain to the community transmitting. We know very well that if someone remains in the community, in a year you will transmit to 10 to 15 people on average from studies. You will transmit 10 to 15 people. Out of those, a number will develop TB. Some people will never develop TB. But some will remain with infection without getting TB. But some, within the first year, that's when infection gets sick. And those who remain in the community, some of them are smear positive. those who know smears, if you are positive or smear negative, you can have TB which is positive, you are transmitting even much more than someone who is smear negative. So, if we are to reduce TB, we need to detect this disease earlier. We need to detect the disease earlier, put people to treatment, and be able to reduce that burden into our community. It's like screening. When you screen for cervical cancer or any other thing, you capture the disease early, it may never even come back when it's captured early. What we have, all of us, this digital X-ray, there are tools we have. All these three tools we have there. We have X-ray, we have the expert test, alpha, we have treatment. Treatment right now we are using 6 months, but we already know that there is a new regimen which has even been put already in the guideline, which is for 4 months. So in the future, we are likely to get even a shorter regimen. And so, all these are available, and we can use them. How can we use them together? By screening actively people and putting them on treatment. And those who are eligible for TB preventive therapy, as you know, TB preventive therapy for those who are infected but don't have disease. Those who are HIV positive, they need to take TB preventive therapy so that we can reduce the source of infection in the community. So this triage, the X-ray, is what is there. That's our whole system of X-ray. And we shall demonstrate it to show how it works. It takes a picture, uses artificial intelligence. You don't need a radiographer to read. Takes a picture, and once the picture automatically goes using Bluetooth on the laptop, there is no wire connection, and the picture and the report is already written, and you have just said this one has presumptive TB. It can also show you someone has got cardiomegaly, so we can detect other abnormalities. Someone has got a nodule in the lung, maybe needs further investigation for lung cancer and others. So the X-ray can quickly, within 10 minutes, you have everything and the report. And so, X-ray, as you remember, in 2014 and 2015, the National TB Program conducted a National TB Prevalence Survey. Those who participated in that National TB Prevalence Survey, there were 2 criteria which were used to define who should provide us a sample to test. The criteria were that if we sample this and we survey this community and this household, whoever was 15 years and above was supposed to, you ask him or her whether he or her has symptoms of TB, cough, what. Based on those symptoms, that person was eligible to give a sample, a sputum sample, which was checked using the expert. But the other criteria was that any person, irrespective whether he has symptoms, you had to take an X-ray. You did not have symptoms at all, you are not coughing, you don't have any symptom. They took an X-ray. They looked at the X-ray. If that X-ray had any abnormal findings related to TB, then you also provided a sample. That was the 2 criteria to provide a sputum sample, which was tested. During the survey, nationally, they found 160 TB cases were identified. Out of the 160 TB cases that were identified during the National TB Prevalence Survey, 8 of the cases had symptoms. 8 of the cases never had any symptom, they had just abnormal findings, X-ray findings. So there are many people who may be walking without coughing, but they have. From that and from many other surveys which have been done elsewhere, they realize that the issue of symptoms is not enough. We need to triage people using X-ray. That's why you see now X-ray, the Ministry of Health has got those vans we've seen, Dict X-ray and more even Dict X-ray, to say we need to screen people and capture them early. That's why you see we are going to be using an X-ray to screen whoever is in those hotspots. So long as someone is 15 years and above, should come and be screened, unless there is a contraindication to screening, as we shall talk about. And then once screened, we shall take off a sputum sample. We shall take off a sputum sample which will be sent to the lab. I saw the TB focal person is somewhere there behind. Yeah. So we shall send the TB focal person, but also the lab person is we shall send the sample to the lab. We are not going to put down the lab here. No. We're not going to have a lab that we have come up with just. No. Everything will go through the existing system. We are not creating any parallel systems. We are not going to create where we shall treat patients. The patients, once they are found in the community, they will come to the facilities and be treated there. If we find that there is a lack of cartridges at the lab, then we procure cartridges and deliver them to the lab to be used by any of those people who come there. So we are not creating any parallel systems. And the data we shall capture, we capture it from the existing registers. The TB treatment register, the TB preventive register, and any of those registers. So this is how the ACA became so important. And now you can see everywhere and say, let's go to the community, Ministry has got 2 vans and to see that we screen for TB if we are true. Because there are many people who have TB and don't know. And so, in this work, we are going to be using all these tests. However, as you know, it is important. Many of you are clinicians. We are told if you are HIV positive, you should go TB preventive therapy. If you've ruled out TB, then give TB to clear the infection so that this person does not have a chance to get TB and he can be source. So we shall be using tuberculin skin testing to those who are eligible. So that once the tuberculin skin test and we read it after 48 to 72 hours, if it shows that you have infection, and then you are sent to the clinic to get TB preventive therapy. I recognize it, but even in our guidance right now, they have put 3 HP. 3 HP is already part of the guidance, and the issue now is opportunity that government has procured that can be distributed with people. Take only 3 months, taking 1 dose every week, and even there's the 1 HP which has been already approved internationally, which is already meaning that you take preventive therapy for 1 month. So there are many innovations. So people will benefit from that in that case. So those are the interventions which will be a package, and I will shortly explain how this will happen. But before I go further, I want to tell you how did we end up here to say we work in these 12 districts to carry out this intervention. This intervention was informed by work we have been doing in Kampala since 2017 to 2021. We are doing a 5-year study, still with the colleagues in Johns Hopkins, funded by the US government. And we were screening people for TB in 2 parishes only. We were working in, those who know much in the division, we were working in Wabigalo and Kisugu. Those 2 parishes, Wabigalo and Kisugu, we estimated that they may have about 50,000 people. We said, we are going to screen every person for TB from the age of 15 and above. And we are going to go door to door. So our team, including these ones and others, would go door to door every household. And those they find home, they were screening them for TB. But in addition, there are people you can't find home, isn't it? Many of us healthcare workers, we spend more time in these facilities, that if you go now home, in our homes, we are not there. There are also my brothers who take us on border. They are not at home also. So if you focus, so in addition to saying where do we go home only, we also worked with the local council leaders in Kisugu, Wabigalo, in those zones, and we ended up also identifying venues where we could do some venue-based screening. So on a Saturday, we
could go at a marketplace like in Namuongo and put some little music, and put a tent, and you tell people we are screening for TB. People came and we screened so many. Every day we could take off like 150 to 200 samples, and we deliver them to the labs in Mulago to test. So there are people now. Also, sometimes we say at this church on Sunday we shall have a venue. So the local leaders there announced they will be screening for TB for free at this site, and we do that. So we realized that some people we captured them, but we also asked people, if you were screened, if you want those we made, if you are to be screened for TB, where would you want to be screened? Some people said, we like to be screened at the healthcare facility, meaning that there are people who still the screening will be at the healthcare facility. But if you focus only at the healthcare facility, there are people you may not get, as I told you, certain groups. And so, but from the data in Kisugu, we looked at the data in those TB treatment registers. We looked at the registers. Even now, for you, you may know that in my register, people come from this parish or from these zones. So we found that there are 5 zones. You know, some of those parishes like Kisugu will have 10 or even more zones. But we found that in only 5 zones out of 20-something zones we worked in. When we looked at the lab registers, with the highest baseline TB notification rate, where these people in my register come from, they accounted for only 22% of the population. Those 5 zones, which are very big, obviously, and they had a population of about 22%. Look at 24% of the 50,000 were living in those zones. But when we looked at the burden of TB, they had TB, they were contributing 46% of the TB. Meaning that the notification data within the healthcare facility can also give us some clue on where TB may be. That may be one of it, but there are others like sometimes hotspot selections, the casting work, and people may say, okay, there are places which are difficult, which was up, but they have a lot of TB based on these reasons. And we shall go through that exercise briefly. So you can see that the data notification we saw informed us and to say that maybe good hotspot case finding can be guided by routine data. The data from where people come may guide you to know what might be my hotspots. Where are these people coming from? If a person came and looked at like a cholera epidemic, there was a cholera epidemic in 1996 to 97 there. Remember me, Chionga was the Minister of Health, and we had that cholera epidemic in Kampala. And there were some zones where we used to get cases from cholera. So you could say, why are these people coming with diarrheal diseases like this? Then it would point you. The same thing with TB. So when you look at where cases are coming from in your register, they may point you, but you may have other zones to discuss. So this work we had done in 2017 to 2021 informed us that it may be better to think of hotspots. Those hotspots may be informed by the data you see in your registers, but it may be informed by also the knowledge which go beyond that data. Because people may say, no, there are a lot of cases here which are not coming and other things. So data notification is one of the things. Some people have been in CAST. They may say, oh, through the CAST process, there were so many cases here, though in the notification was not that. So, and that's information that people think would also inform on which should be the hotspots as we go to selecting the hotspots. And these hotspots are not cast in stone. This time, there may be hotspots. Next time when we come back, we may say this was a hotspot, but now there is a new hotspot. We should leave out this and this, and this can kill. So this exercise will continue. But as I said, there are people who say they would prefer to be screened at the facility. That's how we came up to say, as we write funding for the next 5 years, it is important to think of hotspot selection and also think of facility-based screening. Thus now, we came in with the hotspot selection and facility-based screening, and finally, we have to work in these 12 districts to compare these two interventions. So, the two interventions, as I told you, that's how we came up with screening at the healthcare facility and screening in the community. Overall, people wanted to know what is the objective of this. We want to evaluate and compare how effective and the implementation of this combination intervention. The intervention has got screening, active case screening, using that X-ray. Also, diagnosis using the expert, putting people on treatment, and also TB preventive therapy. That's the whole intervention. Under two different approaches. One approach is the hotspot, and the second approach is the clinic-based. And so we are going to compare how these two compare. Okay, so this is the two. So we are going to compare and how to link it. And we shall be looking. As I said, we are not going to be collecting data as a team. Everything will be going to the registers. As I told you earlier, we were 12 districts. Now there are these 8. So, if we intervene in these 8, we shall look at the number of patients who are in the registers. Some of these will be coming from the community, some will be screened from the healthcare facility. Because when we go to the healthcare facility, as we are doing now, in Kayunga and Kasana, what we do, if someone comes for family planning, he may have TB. So the person who comes for family planning, the person who comes for family planning may just be coming for family planning. But if he's eligible, we send him to the tent to screen for TB. If someone comes for any other procedure, we screen. That's how we do the health facility. So we shall finally compare the number of patients who were identified to have TB in these 8 districts where the intervention was carried out, and compare even with those 4 where the intervention was not carried out. And that will give us 1. But even we shall compare between the hotspot and also the clinic-based to understand which of these. Then we shall finally also come up, what is the cost? What is the cost of implementing this? Remember, finally, these are things that finally the ministry wants to take into global fund application. And they say, yeah, when you came in with this intervention of screening in the community, it worked. There were so many people. But what does it cost? If I'm going to put it in my global fund application as a country and try to see that we apply for money, what did it cost you? So even we shall do the costing to know how this happens. And then using simulation or modeling to understand what is the impact. Because what happens, the impact you see, if you did this now, what will be the impact in the future? How will it reduce your TB burden in the community? And at the end, the cost. It's like screening. When you screen for something early, for example, cervical cancer. Cervical cancer is the cancer #1 killer in Uganda. Cervical cancer used to be #1 killer in the US. But they put in the screening program. When you screen, it will not be a killer. You capture it early and you clear it completely. It will never be a killer in that person. Now the screening, and some of the health insurance, the insurance companies, insurance want to make more money by having people who are healthy. One time I went to the insurance company a few years ago, and I asked them, I wanted to pay some insurance for my parents. And they asked me, How old are they? He told me they were all above 70, so we don't insure. Because they see these people are more likely to die. Now we can't get money from there. So even insurance end up going to the extent, and it's going to come up. In those countries, they go to the extent that if you are a lady in this age group, you must every year go for screening for this condition. If you are in this age group, you must screen so frequently. The aim of them is to see that if they screen you and you have cervical cancer now, when it's still early, capture it within a year, they will treat it at a low cost and be able not to spend so much money if you go down with cervical cancer, which will take a lot of money. So they can say, we have cancelled your insurance policy because you did not go for screening. Because they don't want unhealthy population. They want you to contribute, but they want to keep their population. It is good for us also, because we are trying to protect us, but it's also good for them in business. Because if you have many people who fall sick because they just fall sick all of a sudden, you spend much. But if you keep them healthy, you spend little for screening, it's different from if you spend someone who's on chemotherapy and is in a hospital for a long time. And so the same thing, that even now, if you say, I pay the money now versus paying it later, you could see, you could spend this money and say, this program takes a little bit. It's like Gene Expert. Gene Expert and those who know our spectrum smear microscope. Smear will miss them who are not positive. Expert will see them even better. But at the same time, expert is a little bit more expensive. But it will capture most of those people and will reduce transmission and even burden of disease because people are healthy. So the same thing with this, so you will see the impact. You may spend the money now, but reduce the cost in the future. And so that's how we shall be comparing these things. What are our methods? All the methods we are going to be using, both at the clinic and in this one picture. As I say, when someone comes in who is 15 years and above, he comes in here. We have our staff and some research assistants and other things. You talk to this person, consent him. You must go through ethical. You are told what you are going to be done in a language you understand. You give through all that, and you consent, accept or you reject, and you are free to go and get your sight. If you are informed and you consent, then if you are, they assess if you are ready, are you pregnant? If not sure, then you can do the test, rule out pregnancy. And if you are not pregnant, we shall take that X-ray. Once we take the X-ray, as I told you, you may not have any symptom, but you may have an abnormal X-ray. Once you have an abnormal X-ray, then we assess whether you can produce sputum. If you can produce sputum, we shall send the sputum to the lab. And then, if you can't produce the sputum, we see you have an abnormal X-ray which points to, because the X-ray as we see gives you a report. And say this is presumptive TB. This is maybe cardiomegaly, because there are many of our colleagues who are moving with blood pressure, high blood pressure. We hear has collapsed and died. But because one of us is just working Wakiso, and he was going to the community screening people. We found many people had hypertension, but to find out whether they have even been to any health facility, they even didn't know that they have it. So we are moving that, but at least you can get. So we shall send this person to be evaluated at the hospital, which is nearby here. For TB, sometimes people have got extrapulmonary TB or another type of TB, which may be severe negative. And then we see clinical TB can be the clinician have the decision, the final decision. But if expert is positive, if negative, expert. And clinician says, then that person is told that to be given tuberculosis skin test to assess whether he or she has infection. And if positive, yes, or is HIV positive, is eligible for TB if it's already not positive. And if negative test, no HIV, then that one goes. So in addition, there are 9 TB abnormality that are going to be captured in that system. And those 9 TB abnormalities will then be evaluated at the healthcare facility and then further work done. You're welcome, doctor. Yeah. So this is what we shall be doing, both at the healthcare facility if we are based there, but also both in this community, the hotspots. As I told you, this Dr. Bossa and the team came and selected who should be in this group. We shall have, as you can see, we have 12 communities. These were 12 communities. They are the 12 districts. In the beginning, we don't know which was which. So finally, they chose the times for them. There are 2 which started here. This was Kasanda, I think. Yeah, this was Kasanda, and this was Nakaseke. And the ones which they started in year 1. And we went away from Kasanda and Nakaseke. We went away starting October. Unfortunately, over Ebola hit in Kasanda. We could not even be there if we were supposed to be there. But it was at the end of September when we had finished, and then Kasanda. Now we are going back to Kasanda starting in February. This time we are working at Kasanda as Center 4. That's where we are based for the next 4 months at Kasanda. But from Nakaseke, we were at the hospital in the beginning. We spent 4 months away. Now starting in February, we discussed hotspot with Kasanda, with the Nakaseke yesterday, and we are going to meet at the hotspots in the district. And we are going to be there for another 4 months. But this time, starting February, we are coming to the hotspot and we are in Buikwe. And we are going to be here starting February for 4 months up to the end of May. But we are also going to be in Kayunga. We are also in Kayunga for 4 Kayunga district for 4 months, but this time at the clinic. So we shall be away for 4 months. Not even in the clinic or the district, we leave that period of 4 months. And we shall be coming back for another 4 months. So we are going to be for 4 months, for at least 12 months, total months, here in the hotspots. The total time we shall spend, which may take maybe almost 2 years on, we shall be screening for TB because the hotspots we are going to identify today may not be the hotspot which will be identified later. They may have changed because of our intervention being in those communities. And you see, now TB is more in this community, we should go in this community. So, this is the map for the districts where we are working, the 12. Ujiri, Ikaba, Kauro, Kayunga, Luweru, Nakaseke, Kasanda, Gombe, Sebabu, Butenga, this is Komasi district, Tazama, and Kasanda. Among those 12 districts, as you see here, there are districts which decided to be intervention and others decided to be control, as I've told you. Dr. Bossa is the one who came here and decided to be here, who would not be here. And probably him and the cow and the one who know that we decided we don't care. But they decided. So you can see these are the districts where we have intervened. And you can see, starting this February, we are in Kauru, please Kauru. This map, 2023. Yes, we are here, February. And this
At the facility.
this is this is hotspot.
Hotspot.
Yeah, we are at hotspot.
Okay.
It's kind of where we are. And so you can see this map, starting February, there will be 4. And we have 4 X-ray machines. And there is this. So as we move from this 4 to the other, and come back. And someone mentioned here during the introduction that if they give us this at the end
Of this study.
and he was here.
Somebody from
Yeah.
Kawalo.
Yeah, someone said if we can have this. And actually, we don't know whether it may be the Buikwe district or whatever we have it. But what we agreed when we were starting this project, and the letter was written officially from John Hopkins, because usually this cost about $80,000. This system. And we agreed that this will be a gift to the National TB program. Once we end our project, all the 4 X-ray systems will be given to the country. The decision how the program, because if we are 8 and we are 8, we will say maybe you are reasons, but now maybe people may need to lobby and say we need this in some of this community. But I will tell you that it will remain in. But what I know, we've already given it, and immediately finish, none of this belongs to us. It will be so. That's what I can say. So Kasambia, Ruwero, Gombe, and Kumasi, those are control districts. And you see how things happen. That sometimes that's why this randomization is good. Because me, I come from Buikwe, but they are not getting this intervention. The BHO came and selected us to be in what? In control. That's why they even in making drugs, they randomize. You find a clinician, if Dr. Bosa knew today what we are going to give is the placebo, and tomorrow is what contains the drug, he will tell those people he knows, you come tomorrow. When we are giving the actual one. Because when the people are doing these randomized trials to see whether drug is better than B, even the doctors giving the drugs don't know which is the drug. They tell them immediately you recruit a patient who is eligible as per this criteria, send it back to us, the company. Then the company will now make a code and send you a code. That one should be given X. X resembles Y. They make these things exactly the same and test. So that no one knows which is the drug. It's only the other one. Even the people who wrote the grant and wrote they don't know. They want to make sure that whatever comes out is not biased. And they say, it is better than the other. So now you could see, people would say, let's first wait and others. So, how are we going to administer this? And you put across both arms. We have our team of about 3 people who will be working and carrying out this procedure. And teams will move through adjacent places. So what happens, once we identify the hotspot, the people may stay in this hotspot, and within that parish, they may move from one point to another within the parish. They may say, spend a week here, and work with the VHTs and other people, work with the local council to make sure they inform the people. We need to take the service to the people. There is another nearer market there, all near this place. Let's put it there so that they move within the hotspot, not fixed at one point, and they carry the tent. And so that we shall be moving, and we shall be screening maybe for 5 days. And we can also say with this time we shall also screen on the weekend of this day and other. So we shall be also intermittent. We shall have the screening, we have a tent, we shall bring the tent to move. And our generator there does not necessarily need power. We can
agree where we shall keep our equipment overnight, where we can be able so to sort of keep charging it overnight, but you can go through the whole day, and sometimes we have provided provision for even charging them using solar in case we have to continue work and power is not there. So equipment and that set of equipment, my team will be demonstrating, and people should take advantage to check themselves. Yesterday, I don't know how many we checked, almost the next chair, everybody, the DHO, everyone took an X-ray and said, okay, we are the first ones to test. But what I want to say that we are not at the hospital for the MSC there. We are not based at the hospital, but when we get based at the hospital at Kaoro, because we shall be based there for 4 months later. But when we are based there, one thing that we don't want people to say, I'm going to Kaoro, you X-ray, so that is ababaze oli bwabanga ze mudwali ngaze kulabirira mulwadde nze ngamba nti abo bonna abali mudwaliro lyaffe nga batenda tubakebere kubanga onajjanja obulwadde waki bonna batenda nti naabo bonna abakola mu kompaawo tukoleki oli bwaba ine ekimulese mudwaliro sokulaba mulwadde akoze eki newababuuza mpisi naye bakoleki naye tetusakula beebweru banange bakola ki kati Kaoro wetu waline kutawu olaba baja katwine kudwala bakola ki bwebananga wali mugazi kutawuni awo waliwo otugenda kuteekawo ki te tumale mu kitundu ekyemyezi natukenda kubanga nemba twagala okuceekira twetwagala abo abaana ababaze mu ddwaliro olw'ensonga naye bwebamusawo ayinza okujja nabo tebabakebera abeka ngamba nti ndaba babadde yanyakibira kinaye nga kigamba situgenda kusagula baki ab'emukomiti tujja basanga mu hotspots ab'omumalwaliro koleki yenna abazze attendance everybody bano bale abo bonna tubacekingi. Remember the hospitals are our homes. Olumu ogenda n'obuuza ti mu nnyumba yo omalamu obudde ki bwebala obudde bwomaze mu ddwaliro ebweru ne bwomala ewaka. Actually, we are contacts at the healthcare because the people you work with in office are close contacts whom you or them can infect you. So instead of thinking of the household contacts, you have to look at close contacts, the people who spend time with at work. And these people spend with time, maybe some people go for prayers, some people go to the mosque. Depending on where, some people you spend more time with become close contacts and they cannot infect you. So, we shall be coordinating between the health facility and us. Usually, when we go to the health facility, which is not this time, they ask the hospital to give us a place where they think is good and we demarcate. And like in Igalo, they gave us a place in the hospital beside there. And that's where our team is based for this 4 months. So we agree and we demarcate a place where people, and we talk to the people in the hospital to make sure that the people are referred to that place. We are going to be selecting the hotspots together. We are going to go through that exercise by letting us know which are the hotspots in Buikwe, and also we shall also share what we thought might be, and we agree on which hotspots start with and work on. We are going to be engaging the community, definitely through the community leaders and the PhDs in those places which are selected as hotspots. They are the ones who carry the megaphone and inform the people. They will be screaming here, this is this. So we make those lower level also engagements to make sure that people are aware who are these. Yeah. As I said earlier,
The testing will be done at those designated labs. And that's why we identify which facilities are near those hotspots. You cannot say, I'm staying here, there is a center there, I'm sending you to Kauru. No. We want the people to choose which is near and where they can go. So they test from there. For us, we shall capture data from the registers in all the facilities to see whether the numbers have increased or they have remained the same during the time. And so we make sure that people, and as I said, we are not creating any parallel systems. Everything we do, we channel it through the health system. And we shall be looking at it because you can diagnose people and they are not linked to care, but we shall be following up with that. So I think, as I said, we are looking at the TB tester, without TB tester, TB treatment tester, and TBT tester. And every 4 months we can collect data in those registers to see how the numbers have changed and other things, and then move forward. So we shall practice outcomes as I told you. Patients, districts, county, and parish of residence. So we shall be capturing that information. Is this one coming from the hotspot? Meaning that if someone is not coming from the hotspot and others, and he has come for testing, we shall test him. But if you want to look at the actual hotspots, we have information whichever the hotspots. But you cannot say someone should not be screened. There may be people even from some other places that we there. And we shall be looking at either new relapse or other pulmonary bacterial confirmed and the time when TB preventive therapy was initiated. As I said, and as I conclude, here, how will we compare the effectiveness? We shall look at the difference in TB, which is bacteriologically confirmed notifications, between our intervention, the 8 districts, and the standard of care. The 4 continue to be the standard, but it does not stop any activities taking place over there by the program. CAST has been going on, isn't it? So any other program, and some of these programs, when they come, they are uniform everywhere. So if they have impact, the impact will be the same, uniform. So we know that. But we shall also compare the total TB notification between the hotspots and facility based. We did hotspotting and also did based at our hospital. What are the differences between those two captured? We did the district, but also comparing if we added both. How many of those people initiated TB preventive therapy? If you look at the hotspot focused versus facility based, and the difference in number of people diagnosed with TB through standard activities. So we shall look at how it's implemented. Implementation in which we may say we are going to reach the assumption that in the hotspot we should be able, at least at the minimum, the hotspots we select as parishes, to give us a population of screening of 10,000 people in the 4 months. If we can screen like 10,000 plus people. And so we are looking at hotspots. And those hotspots have a total population of say probably 10,000 who are maybe 15 years and above. And so, meaning that we plan to reach those people. Whom did we reach? Who did we not reach? And why did we reach? Because that gives us a chance to understand what were the barriers to people being screened. And we can look at the cascade of care. Proportion screen, diagnosed, treated, etc. Looking at that whole cascade of care. Maintenance of each of these, how have they contributed? And we shall look at the cost. And that cost will help us, as I said earlier, to understand if you intervene with this, what does it cost? How much do you need to put into your budget for that? And we shall look at the reduction of time to diagnosis. We shall also look at how this intervention, if you put it in the community, how would it reduce your incidence of TB? Right now, Uganda's incidence is about 200 per 100,000 population. You say every year there are 200 new cases of TB in every 100,000 population on average. So meaning if you multiply 200 over 100,000 times Uganda's population, you will get how many new cases come every year, which may be about, if you look at about 90,000 new cases every year estimated. If there are 90,000 cases, then the program will say how many of those do we notify in our facilities. So if you notify 60,000, 60 something now, it means almost 30,000 cases remaining to the community. If you came in with intervention, how would that intervention impact on that incidence? Because the issue is that we want to end TB, according to the NDTB strategy, says that by 2035, there should be an NDTB strategy, which says, on average in the world, there should be less than 10 cases per 100,000. So if you add all the cases in the world, new cases, and you divide with the world population of maybe 7 or so billion, you should have an average of less than 10 cases. And then that one, they will have reached the NDTB strategy of 2035. And so even as we are saying, our hours is 200. If we impacted and this based on this over 10 years and put in that money, what would be its impact on the number of new cases? Right now we are at 200,000 per that. And that's the work that you want to do. So I will stop there and invite for any questions, any discussion, any comments, and then from this we should go to also trying to now talk about which are our hotspots and be able to select these hotspots together and agree which are the hotspots. So for now, I'll just thank you for listening and wait for any questions.
We have the background of CHASE TB. We have CHASE, we have CAST, we have catch up, we have AIDS. I mean, since we have our MS from Kaolo, I can say hello. Members, most of the newcomers who are just joining us, can introduce yourselves. As I'm waiting for questions. I know me and Dr. Shwelu and Maria, thanks so much. We are there when we are waiting for intervention. So, we are going to that team with Manya.
Many challenges. One is no case detection. The second one is poor momentum or success. Again, and when we identify these cases, we don't follow the lesson. That is where our problems are.
Maybe before he sits down, there is an issue of the gene expert at Kaolo. We had challenges during CAST with those running those samples. We had HR issues at Kaolo. We also had, they told us that the lab had issues with their S. I was giving wrong results. So that team was even bigger than us. And we've communicated to him somewhere. I don't know how it is right now. Maybe you could say more about the challenges of the expert, because after screening, the samples will be brought for running at the expert machine.
Apart from the diagnosis is going to be made by the president, not on the screen.
No, the diagnosis is going to be made at the healthcare facilities.
So that brings in the one, the HR, the staffing norms and the department of the and we don't know, I don't know if it is, I mean, the cars around, how soon we're going to replace the HR issues. The second one, that using the government IP we have yesterday, we very first shortlist replace one of the staff who transferred his services elsewhere. Now, I still believe we put the number to catch up on that we identify for hotspots especially, because here we have I don't know whether that was a hotspot or not. In the sea, which identified 6 plus 15 That was unhappy. That was very happy.
Grace, you clarified those figures.
They sent 6 samples that identified 25 cases.
This was during the past,
Yes.
from which, from one zone,
One account.
and that's a real hotspot. Is it a hotspot?
The hotspot.
Yeah. And that's one of the reasons to identify those and we focus on those. However, trying to answer the questions, I will start by saying that probably in the school, we work with the car. I'm not going to say that I'm going to be human resource. I will be right. What I will do, if the cartridges are not there, I will bring cartridges to support the work in the lab. But I'm not going to say I have employed this person to do it. That we know. But what I have come to realize that where we have worked so far, because we are not saying that we are going to focus on the codes. We want to focus on those facilities which have been expanded within the district. So that if a hotspot is in the sea, what is the nearest facility for people in the sea to go if you are to find it? And they have been expanded. They found out. Okay, then you need to pick a word for those who can nearby. And so in that case, we look at that. But when the gene expert Mikao is not working as you say, we are working on this.
It's very sensitive.
Yes.
So now this is in the lab of the issue. And we need that to listen. So let's see if I so that's what I think we do. Whether we put the iCard to support the functionality of this.
I don't want to commit here and then at the end of the day say this man lied to us. It has not been a common problem that I have encountered, but I need to look at that also. I can't promise that this is what I'm going to do. But you talked about case finding, no case finding. Yeah. This project is going to improve case finding. It's so key. But we also want to make sure that we're going to And one of the work we were doing, I don't know that cover was one of the 99 dose sites. Yeah. And that was one of the work we were trying to do and has handed over to Ministry of Police to make sure that it continues. I don't know how 99 dose work will. So in that case, we want to see that even if there is an intervention beyond what we have done, it should be done within the facility as far as case holding is concerned. But we are focusing also on identifying people in the community, but also all those who come to the facility for any other service so that they can be captured and also treated. And so one of the key issues which is a challenge to many of us is, I think, the issue that time, also people to understand why they should take their medication for 6 months. Because at least, as you know, people take care of this for many years. And they continue to live and care. But TB patient, when he takes drugs for 1 month, he feels good. The appetite is back. The weight he gains. And he's thinking, why do I take these medicines? But I think there is an element there in giving that patient time and giving to understand why is it important to take these drugs for 6 months. And only 6 months. And that times comes in because of also workload. Sometimes if you have many patients, you may not, that's where sometimes this group council with education to say these drugs are important and others may help. Because I found that if you know people are taking blood pressure medicine for a longer time, 6 months, maybe people don't know. Sometimes they say, they told me you saw this medicine, but now I'm feeling good. And this medicine is making my brain red, everything red. Why should I continue? And my appetite is back. But if you understand that you can get it back, which is even resistant, and even transmit it to its or other people, and you may not even pitch what. Sometimes because you care about your loved ones, you may care about your life more than what you have done because you fear this problem. So I think there is a gap there. Taking medicine is 6 months. The other things are yes. And each of them is taken once a day. So you can see, sometimes you think, you can understand what are the benefits of taking this medicine. And why should you take it? Why should someone spend money for 6 months instead of giving it for 1 month?
Okay. So when I have this chest abnormal and I proceed to gene experts, the results are gene experts that would not conclude afterwards. My question is here. Because to me, if I have a positive here and I have a negative here, and this I have my signs and symptoms, I will treat according to the language. But then, to your algorithm, when you have a positive, a negative, you have a battery test, which you may not have it around here. But for the study, you have. But this is a case that I can treat for clinical diagnosis. So what will happen to my sister when he gets I'm not just expert and negative gene expert? If he has a diabetes,
if someone has got symptoms, if he does not have symptoms, we are finding him in the community. He has an abnormal X-ray, and he does not have the expertise that person. But if he has symptoms, he should be evaluated at the clinic for further evaluation. But if he does not have symptoms, he should be able to go. But for the other algorithm, I think the algorithm is depending on how you are using X-ray. If you are using X-ray to diagnose, versus using it to triage. Because what you are bringing in is that I'm in the clinic, I have done X-ray, and my expert understanding this as a test, and I'm not sure. Is this abnormal? You want to add value on what you see. If it comes back maybe abnormal, you are going to treat. If it's normal, we say maybe it's the world's protective infection, this person to somebody is so my thinking is that no, we are not doing things contrary to the X-ray. We are using the X-ray as a triage test.
Screening.
You can use X-ray within the kidney for diagnosis. But here we are triaging the same. As best, we've seen many people who have abnormal X-rays. And if you take off expert, they are positive. Based on our national survey, but also based on what so meaning that we are in the community, we are triaging. There are people who are working, not cough and don't have any symptom, and then they have TB. If we see they have abnormal, we want further to take off the expert, and if they are positive. Yes, for ZN, why don't we do work to improve them? ZN. No, we have done a lot of work to improve ZN. There is a study we did in Korea a few years ago. In Korea, there was Korea Test Center. Is it 4 or 4? So at Korea, what we did there, people could give a sputum. And that sputum was ZN. And the recommendation for 8-year-old people was that for every person who is HIV positive, the first test was ZN, was the expert. For people who were HIV negative, it was ZN. The commission have changed. So what we did in that study, we had border at Korea. Whenever any test was, even for positive, whenever expert, it was inexpert, ZN done, we split that sample into two. The sample was taken by border, Buikwe Center. That was now the Buikwe hospital. They had expert. And that expert had that software called expert alert. Now, once the result went in for the expert, we got the telephone number of the health facility in here at Korea, and also got the number for the patient. And once the result was positive, we sent that SMS message to the health facility, but also we sent a message to the patient and told him, go back to the health facility, your results are ready for them. We did not just disclose, because sometimes the phone is with another person. There were ethical issues, other issues. So expert and how we could do normalize gene expert, how we used to be expert. ZN, we've done a lot of work and some of it has been. That's why even moving from there was 3 seniors in the beginning. Based still on the work we did, the average was 16 points to 2. Then even now, the issue of saying sport, you do the sport once positive, you don't have to meet for the morning as we used to. So there is also work on that side. But here, the fact that now gene experts now becoming the one module gene expert, which we tested in a number of health facilities. I don't know which one is here. St. Francis and others. We had one more. So the expert and even the salary testing. What is it? The one for which is also one of the kids and molecular testing, which the ministry is also proposing. So somehow we think as much as they want it, get it closer. Also, president. So we are not contrary to the organism of
Okay.
and the doctor staff is part of the team which is but this is not common.
Then that's here from Center of Excellence.
Yeah, you
Those of the normal results that our machine that provide. According to what said and what our elders also said, from the recent flood coming, where we had having a number of positive cases. When we look back, the samples we have brought to our because we have a hub and it's one hub, one main hub. Some of the samples we are taking to Ayunga help us do the work. So the results that came out from Kaolo for C-Maiden, we had 8 cases which were positive. And the rest of the cases came from Kayunga, those positive cases. So maybe there is something, as the doctor has mentioned, because it is a big hub, but we only had it for C. Then the rest of it, whatever came from, and those positive results came from Kayunga. So something must be checked. Then when Doctor mentioned about our business success rate, our
case holding.
case holding and business and people who remain in detention or who complete their treatment. Maybe Doctor, this issue is about the cases that come to us when they are in critical conditions. Being that we are in a hospital, we get a number of cases. We get a number of cases from around Mukono and people come when they are in critical conditions. When they come in critical conditions, their diagnosis for TB is made late. So you find somebody who is HIV positive, at the same time is having critical meningitis, the CD4s and XXX, we expect little from such a case. By the time this person is started on treatment, you just look at everything that goes around this person. At the end of the day, some of them even die in their first week when they're starting the treatment. Maybe it also affects our treatment completion rates. The death is also there. So my concern also my question was, after now reacting results, the study is going to be done in the Buikwe schools. Yes, but we have our sister district. And remember, we are at the borderline of Mukono where our work is. And we get a number of cases from our nearby villages nearing our hospital. And they are these villages are in the Mukono district. My question is, how are we going to interpret this activity with the people from Mukono?
Okay.
Yeah, that Dr. Ashimi Jackson, the point of numbers is, when you did the cast, the truth is, she has more numbers, even if you drew data for last year. So, when you did the cast, she identified more numbers, even more than Kaolo. And now people thought his numbers are forged. A gene expert really give you forged numbers. And the market, because samples were transferred to Kayunga. I doubt whether Kayunga gene expert was told. Let me tell you, we did a control again, by the way. because I got a call from those staff here, even when I was concerned, I talked to those guys, was saying, it has to be AZ and those guys. I sampled 5 of those. These are also positive.
I'm not saying that.
So let us,
I'm just from what the date was saying about the faultiness of the machine.
No, it reads, it just gives error. It doesn't read when the temperature is so high, as Dr. Chibere mentioned. It doesn't give you the negative, but it reads error. That's what we got. Yeah, that is the issue. Yeah.
And now the issue of closeness and others, as you can see, some of these boundaries are created overnight, and many times the people still use the services that they got. And in many cases, it may not be that if we look at, because when we are trying to demarcate, there may be some parts of Mukono which probably come to these units. We are looking at the catchment area more than necessarily the actual district boundary.
Yeah.
That's why you will see some parts of Mukono is carved out of Mukono.
Yes.
Yeah. Some parts of Mukono, people are more convenient to go to Kawolo Hospital or the health facility this side. Yeah? So when we are looking at the data from where do people come who go to these facilities in Buikwe, we saw that. That's why you see some parts of, and even when we are looking at those parts of hotspots, we are looking at those hotspots which fit, if the person, Dr. Chiberuini Kawolo says, this part, I don't know whether C is in Mukono or is in okay. So if there's a hotspot where you see people coming every time to this facility, whether the boundary is here and is this way, that's an area to count as a hotspot. So that when we are looking at the hotspot, that's part of it. So sometimes the boundaries, real boundaries, may not mean much, especially when it comes to these diseases. And so that's why that may, the actual demarcation may not say that person, the boundaries here, live there, and here. Sometimes we find the boundaries by the road. This is Mukono. This is what? When the people in this township and say, what would you say? And whereas these people come to this clinic, and so those are boundaries, but we are catering for that, and we are looking at more where people are getting that service.
I think Dr. Achilles, you actually presented it in the areas where you are, where the project is. Maybe you can go to that slide. It can cater for, because it really shows that actually not the whole of Buikwe is under this study. Like when you look at Kaolo, you see this normal Buikwe district. Our district actually is this. It is this. It is this. Like that. So these sub-counties here, because we can see even these people from Nagoje, they are here. I think that is the reason. Dr. Achilles is saying that the project is going to be in Buikwe, but apparently, when you look at Buikwe, C is not part of the project area. If this map is okay, because this is actually C. This is Nyenga and Nanja. Maybe they are also not part. So I think for Kawolo Center is capturing these those geographic areas. And then
This part of Mukono is in this.
these are Mukono. These ones, they are in Mukono.
You see, because
This one.
when you looked at the data, where
Yes.
these people, when you go to the facilities, even those lower facilities, where these people access. Because what you want finally is to compare if these people are accessing the facilities within this place, say, catchment area for our, and then you want to compare
screening at Kaolo Hospital and screening within these communities. They are looking at everywhere. It does not stop saying there is a hotspot here which we think we may need to focus on. But in terms of how we look at that data may be different in terms. If all of a sudden these people during the cast were seen, but normally where do they go for services?
You go to Mkokonjero and finally to cover that times. But
But there are more to go to
Mkokonjero Hospital, yes.
And when you are looking at data from people, if you go and look at the data from, say, Kaolo, and you see the catchment where the people come from, where TB starts, you find that some of the people here maybe are more like it, but you find maybe one or two like that. Yeah? So, and that's the focus where you see these Mukono. If you look, you say we are looking at the demarcations, you may miss out the important question we have to ask. And that was put into consideration as we are trying to work out some of these things. And these boundaries are there, sometimes they are by the road, but people are still getting the service in this time. Yes.
Now, since this one is a study, so how do the study is going to be conducted in which district? Or which region? I was studying Kayunga region, because currently we are under Kayunga. If Kayunga is part of this and Mukona, so are you looking at a district or a region? Because we look at the catchment, we somehow and then the other thing we want to understand, maybe since this one is a study, I think it's different from past. Past was just identified, and this one is being a research study. It has to be maybe with a hypothesis, whatever it is. Okay. So we need to understand some of those things. So that at the end of the day, when we are sharing the results at the end of the study, we understand whether what you expected is what you got.
Yes, then I have this.
Do we ask you one question that is answered or several questions that they answered?
I wanted to.
We may not finish. If we get all the questions together, and then they are answered once, maybe you give a second round or something. But if you let one person ask, then another ask, another one, we may not. No. That is probably you secretary finance, chairperson of finance committee. So, but then we have a chairperson, one meeting here. Akilize questions on us here. Kubaba day kuwagia nyo. Question here, then zonna. But answer to problem. When I get a question, it did not go for it.
kakati expiring kunye singete baba indagala ngati bali kozesesa ngati bali bali kozesesa chiti
kakati awo nina kwansa kutandika n'obukomiti chairperson wa finance committee. Ekyo kirimu emirundi ebiri twafunako twali tukola ekirimu especially kyajjali mu east Uganda n'ebiki nga tusanga kino abalwadde tubagamba nti eddagala lyaweddewo bafunye naye erikoze ligenda ku expire lino kati system ya gavumenti omuntu eyagala okuva ku ddwaliro lyaki okudda ku ddwaliro eddala olina okukolagana ne DHO. Ye communication eno ebeera ku malwaliro nagamba tetulina ddagala tebanaba kutusabira National Medical Store naye era nga tufuna permission okuva wa DHO na biki byonna ne bakkiriza eddagala ne liva mu ddwaliro teri mu disitulikiti yemu ne ligenda ku ddwaliro erya disitulikiti endala abantu bafuna eddagala ekyo kiri nnyo communication ey'abasawo DHO n'abantu nno waliwo amalwaliro agatalina abantu bangi
bakita redistribution.
Ekyo kikkirizibwa nga police mu channels abantu babanga bafuna eddagala ate participate kubanga ffe twali tukola naye twesanga nti awamu tewali Dr. Alex Kyamwesa tebabanga that distribution is allowed provided it goes through the right channels. Kikuzo kyo hypothesis yaffe kijja kwasalirira mu region because bwe twagenda okukebera ogenda okutugamba webagambye twatuka tutya ku maapu eno tugamba nti kino erabikalikati eno bwe tuba tugenda okukompeyalinga screening from this tulina okukompeyalinga ne screening from encatement eno tukulaba nti kiki ekirimuwa effective. Is it better to screen from this or is it even if this kiki what does it cost? So kati eno catchment area gyolaba ezo gamba nti region sinza gamba nti region eno eyitibwa linnya kinaki kubanga era erusi emuliko district yennyini boundary zaayo naye golo bagambye nti ogenda okulaba nti nno kano tetwakateekamu tugamba tekalimu kyasinziira ku bantu bano bagendamu
so tekagenda kubeereramu ddala
tekitegeeza ekyo abagadi nabagambye
kuba eyo yerisi gye twogeramu
walisinga kati si tunagamba nti si based on our cast information naki should be a hotspot okiwulira tujja dikebeeranga hotspot naye bwe tuba twanalizinga data yaffe tuyinza okugiteeka waki naye ng'abalwadde tubakoze ki kiri different okuba kino abajja awo nnyo bwe tuba tubatadde ku eno kiyinza okulabanga nnyo ekinene nnyo okusinga kitukola ki naye nga tuba tukola ki tubalina so ekyo hotspot kyetudde twagambye kitula nabagambye nti no hotspot tugenda kuzogerako kiyinza otatwalakukuyi tusabe okubikyali hotspots fe zetulowooza fe twatulumya kakinteeyo tulinamu n'engeri gye twalowooza bukyali hotspots based on some data bitujja okushiraga briefly naye twagala tusooke tubrainstorminge tugambe bukyali hotspots kati ng'abantu bagambe nti based on cast twakizuula nti eno ki hotspot. So that is one of the hotspots which was identified. Then we can now say which are the other hotspots. But these catchment areas was all about the map. Twas basing records. Twatwala entuufu z'amalwaliro agatali kyokakawo amalwaliro gonna ensinazonezitunuulira bana basinga bagenda ojja kulaba nga bugambye nti nkoko njeru gye basinga okugenda naye nobajjaera waliwakola ki sotubanga tugenda mukukulira totubatuza okugenda nga kitubanga twagenda tukola era tukulaba nti no nga mu districts nyingi ojja kusanga nti no ne mu districts ezimu nga ebitundu byotute tebigwadde esalire mu district eyo bigwawaki walala because nga bugambye boundaries are sort of made sometimes oluguudo lwe lubasalamu naye nga ne charge mugenda muki yemu naye ngaoluguudo eboundary ya district eddwaliro lyerimu omukolera byonna byerimu akatale mugenda mukamu naye muli weri ono waki wende era omusolo oli asasula eri naawe okola ki osasula eri. So those are the boundaries.
I think to add on, I think what was confusing, we thought it was a Buikwe, but it is actually for the facility. No, it was kwebazi labeling zao aneyakati what areas. So it's not specifically for Buikwe. It's actually Kawolo and it's catchment what area. When you look at Kayunga, the same. When you look at all this, that's why they have listed on the facilities, not districts. So I think that is why. But Dr. Achilis, my question is still administrative. It is administrative, and you partially handled it with Dr. Chiveru. It's about, because you said after finding those abnormal X-rays and taking off samples, yeah, they will go through the normal system. But we know that the workload at Kawolo, at the lab there at Kawolo, it will increase because of the project, this study. So are we planning anything for the lab staff there? Maybe a motivation, or, because it's the workload certainly will go up. And as we mentioned, we had issues with the people who are running those machines there. And at one time during custody, we had even a plan. I don't know whether we did it to get some other technician from other parts of the district to put them at Kawolo. So we had to, they needed upkeep doing so. So my question is whether you planned anything for the staff where that this gene expert will be running because of the extra workload. Then the second question, the second issue, maybe will be after the study. I think one of the things which should be recommended is to recommend that it should maybe be a standard for hospital services to have those machines as screening machines for what? In outpatient to screen, because we've been using questions for somebody to get somebody who comes and what. But if it is a standard that whoever visits the hospital and interacts with that modern X-ray, I'm sure even the exposure is very small. So I think it should be a standard. Maybe at the end of the study, we should look at such conclusions.
And we are going to look at them together. And I think it should be a good recommendation. That's why we are screening everyone who comes to the hospital. Then we shall see how many of those people who came for family planning. Because we shall record what was the reason to come to the facility. I came for I came for family planning. I came for hoping something else. I came just for a different condition. So we shall look at that. When we screen the health facility that ended up having,
Yes.
and that can support that recommendation.
Yes.
To see that there are many people who come to the facility, and maybe even they are just attendants, but we have found this still in attendance, meaning in the class meeting, so meaning whoever comes in. So I see that recommendation, one of the things that we think will be supported by them. Because, but for the first one, of logistics and others, as I said, I cannot guarantee that we are going to do that because it was not part of it. Secondly, from our experience in Nakaseke, where we are done, and also in Iga, we've not seen an increase. And actually, if I look at the timeline, and maybe I wait, the timelines of getting back the results, the team there can mention, they are actually very timeline in terms of the samples. Maybe you can say something about the timelines of getting back the smart results from those samples. So we have not seen that, but if it came in as a concern for things, then we need to sit down as a team and discuss it. Yeah. What is the timeline for expert?
The turnaround. Yes.
It's usually the next day.
The next results.
So it's like 24 hours.
Actually, I had you being shocked with the results.
Oh,
See? And then mine, we got very many. In one some count, we got over 4 cases of TB. And my referral facility is our hospital. We think that we got to know what help us make screening because it appears mine is one of the hospitals.
And then this one brings us for the other one, the first one. There's a workers 2 years screen. I think those who are here, whether it's the workers or not, take advantage and screen. If this machine happens in one, please take advantage of one.
And screen.
That should be a given. You know, we were trying to screen one of my students who was screening medical students because we were trying to compare the students who come to medicine in Mulago and the students who go to veterinary medicine tend to have big classes. They were all mainly being PCD at that time, same degree. Some went to CHASE and this. So we assume that the background prevalence of infection is the same. And one of my MA students who is now, I think, he was from Southern Sudan, I think, or the TB officer from Southern Sudan. He did that study to compare the prevalence of medical students of TB infection using this preparation. For those who are first year, second year, third year, fourth year, fifth year, also in veterinary medicine. Because we assume that if in the first year we came from the same background and we were together, you look at these other ones, if they are higher in medical school, which appear to be higher in the subsequent years, showing that the environment in which you work as a medical student was exposing infection. Because the people who came from the same background are not quite as high. And so, already shows you that we are in the wards. Imagine our colleagues who passed on. When someone came in Ebola, in Mubeni, and you know the story of Ebola, where people went for surgery. Because someone was bleeding and the thing was bleeding, I saw something. And they went in for surgery. So you see, we are very exposed in the hospital. Someone comes there feeling all the things. The first thing is how do we do the ABCD to save life. And by the time we realize, sometimes we don't have even a glove nearby or something. So protecting ourselves is key. Let's all screen, let's encourage our friends to screen. But you know, sometimes do as I say, does some people. And but let's take this advantage of screen. And maybe the hotspot you were talking about, I think maybe even take time. Maybe now let's move to the hotspot because you already bring out an important point that the cast informed us like this, and that's the information we are interested and knowing which are those parishes in that sub-county we're talking about that we should list and say these are part of it. So maybe let's now move into that section which may take us a few minutes. And then as we move through those, then we answer even any more questions. Yes.
Thank you very much, Doctor. I appreciate your actually, I have two concerns. But before I go there, I would like to explain our sincere gratitude for our sisters. You know, it is now some years that we have no they have received that warmly. Thank you very much. And now the concern, you see, as a physician, we always find it difficult to identify immediate markers. And sometimes we always use the X-ray. And this time around, we have studied 15 years.
lab took all the. Thank you very much. And the taking is not about taking. The taking is about where do those people get their services. It's not about taking. You are just trying to be scientific that where do those people, based on the data looked at. And as you saw that even now we end up saying, the people you must think that this is a hotspot. And we may go there screen, but it may not be the actual catchment area for that. Yeah, and that's the issue which I don't want to say we took. No, we looked at the catchment area to make the right comparison. Yeah, then the other issue of pediatric TB. This is a concern. The same question was asked in Nakasiki yesterday. The children is a concern to all of us. Pediatric TB is difficult. And using X-ray in children, even the artificial intelligence algorithm has not been fully established. To say this X-ray for a child like this points to TB or not. And so, somehow there are many still questions. And you don't want to mislead people. And even when we went in to apply for the funding, but also to apply for its colleague through the Ireland, through National Council, so all what was approved to work in 15 years and above. There are still concerns. It's like even in paradise, people who are 3 months, within 3 months first trimester. Things are still forming. You don't want to, but after that, it is okay. And so these are things that you don't want to go in, but I can tell you, pediatric TB is at the forefront of the global work. Even there is a lot of work going on in the lab right now. Trying to say, can we use food? Can we use, there are many non-sputum based things that are going on. And there's a big USAID funded project right now which is starting. And it is going to still be is on what? It's a concern. But for this project, we are not going there, and this algorithm of ours, which is not yet there. Because you need to get a number of X-rays, so many thousands, of which so far this is pediatric TB, and make that system be able to read and understand. Because this is based on true pictures. Picture points to this is presumptive TB, this is not. And many times it's quite accurate, many times. So maybe let's start the class, and as questions come in, we see the questions will be answered and we ask as we go on. Because now what we want, yes, the last question, we want now to list. We check history, okay, it's put in consideration. But even as a clinician, someone may still have symptoms. You see, he has come back, gene expert is positive, but by even the time you order gene expert, he has symptoms, and you see, this may be still TB. And you do gene expert. Gene expert will also tell you whether it is resistant or not, because he may have been treated, but he had some resistant bugs and others. So in a way, you can establish that
the time. And we do take history, whether it was previous treatment and others. The issue of scaling and other things, yes, definitely after you do the X-ray, you take off the sputum. If they are, those people are based on scales, not necessarily scars which remain, the system will be able to detect that this is probably not maybe due to some fibrosis or something, maybe something. And in addition, we don't rule out that finally the final decision is going to be made by a person, the clinician who decides this is TB or not. And we put into consideration previous history, what is it, what does it, and others. Definitely as a molecular test, it captures the bacilli. That's why it's not the gold standard in the cell. We use culture which we grow the organisms and be able to know this is a living organism. Yeah. So now,
I guess I see doctor may take another step for protecting the hotspots.
yeah, now we are going to the hotspots, which should not take us. And already people have started talking about which are the hotspots. And maybe what I would ask, I'm trying to ask that we need to identify hotspots. Hotspots within certain sub-counties, but also within the sub-county you may find which are the parishes to focus on. And also providing reasons. Why do you think, already I have started hearing reasons. So for those who are saying this is a hotspot within the catchment area, and those hotspots, you name them, the sub-county, the parish, and then we see finally the number we come up with, and we want to see that the total population within those probably could give us something like 10,000 people plus.
Some guidance. The facilities who are here, okay, Nagoje, Tendero, Najembe, and the Buikwe CHASE. When we are doing mapping the catchment area before the catchment area, I mean how. So by sub-county, please aid us to tell us how many hospitals you have in sub-county. Because most of your patients go to work. But maybe some get lost between Kaulani and Najembe. So I will start with that probably which hospital you have. They are getting more numbers. Is why you got this treated? It is that one actually. Where patients are coming from all over coming from this account. And that's why we are here. Not here by mistake. So it has beginning with our hours, then this and the other. So now gender.
Which parishes, which do you think are hotspots, and why do you think they are hotspots? Which
So machine ya kutambulanga ngegenda wanebona wiki obadda
ezo pale wiki baba abantu banyine kusoma kugamba kijja kusinziirako okutondako
genda awalala.
Muyinza n'okutambula within the same parish, different places. Because you want to take the service nearer the people. But you want to focus in these identified hotspots. But as I told you, this may be the hotspots identified now. When we come back again, we may say, from our previous task, this was a hotspot, this one is no longer a problem. So those can change. For the total 12 months, some hotspots may remain as hotspots. Others may change and define them with others. So now we want people to say, in this sub-county, this parish and these parishes, or this parish or this parish is a hotspot, and we list them, and also give us a few reasons why you think those are hotspots, like people are saying this and that. So let's start. Any volunteer to start?
Nedda tube more systematic. What is sub-county by sub-county?
Okay.
Yes. Tumanye nti Najembe mulimu eno n'eno. Tugende kweddirira ziri already there.
Fine. Let's now look at them. But then there may be others which are not here. I don't want to limit people.
I'll give you.
Okay.
Yes. But let us begin what is here.
What is here?
Then we shall talk after them.
Okay.
Najembe.
Who?
Sacha.
That's Jembe is a sub.
Najembe the division.
Yalibaddenga sub-county. Yali sub-county. Naye kati because it is upper and having that
Town council.
and now it is the
Najembe
division.
the division.
Yes.
Okay, Najembe division. Yes.
Then we have
Give us the parish name.
Sacha.
Sacha A.
Sacha.
We have Sacha A. The parish is in Sacha. But we have villages, Sacha A and Sacha B in the same parish.
So those zones are good to focus on.
Yes. Then there is Wola village, still in Sacha.
Water village.
Where Wola is in Sacha parish.
Kakati eno being urban, basita words. Yeah, maybe it's all.
Water parish.
Is it that? Can we use it?
Wola parish.
Water parish.
Yes. Then we have a baby camp. Yeah.
Uvonya.
Uvunya what?
Munya what?
Uvunya what is Betty?
Baby camp.
Betty camp.
Yes.
It is it's still the same
Same body.
vision.
Okay.
Okay.
Thank you.
And what are the reasons? What are the reasons why you say they are?
Whenever we do a tipping casting, we get many members. Yes. But we do like within screening at the facility, they are getting surgeon.
Also within the university.
Yes. But when we do a tipping casting going to villages, then they are camps.
Yeah, comes. Meta comes.
Okay.
Thank you.
Thank you.
So you go to another
So,
entity.
password, some addition from this.
For instance, in Sacha, we have a market venue. Market. If at all, one person is infected, like that, those vendors who are, that market holds like 1,000 people. So there's a bit of congestion. So, what I see, one is infected cause. Then when we go to operation list, those people who are in the camps, remember, most of them, some are with small hands, also congested in one camp, meta camps. So, the meta camps can easily also be transmitted disease in those cases. And when you also much Kenya as a word, the population is also big. Because the numbers of bricklayings, these were who are cutting sugar canes in plantations. So, it's also
Okay. Shanza Kiso. So that's it from Najembe. Let us hear from Buikwe. Listen that three. That's the better one council. We have a hotspot in town council. Yes, tell us.
Very unique is this evening and the Buikwe as a town.
Missing is in which parish?
It is university.
Missing is in which town?
It's a village, River District,
Hey.
MBC.
I think
The
they got
casual brothers.
this way. That's true.
They are casual brothers, they are those ones who work in sugarcane plantations and they do smoke, take tobacco, and they interact with people in that town, local town. That's why I'm taking that over. And another can be this prison.
And they have failed.
Yes.
Yesterday, I saw so many people. That prison has almost 50 people. They were so surprised. We had a meeting.
I don't know whether because the prison, how would screening prison is different, and we may need to ask because these are institutions where if you are to do something, you may need special permission.
No, we have a health facility there.
Do they come to the health facility?
No, the prison itself. Elina facility, which is part of us, it reports with us. So it is very easy for us to go there, using the Musao there, and you do the screen the prisoner there.
My doctor, I want to add on that prison is so complicated because when the custody didn't participate, we wanted to get permission from the Commission of Prisons to allow us. So even in this case we didn't participate because of those.
I know because as a prison, there is definitely services which are government and through NTLP who are focusing on prisons.
Okay.
But
So we
it
leave
may
it
not
out.
be easy to say you are going to do a study in prison coming from the community.
Okay.
That's what.
But also, Doctor, I've noted that camps, they are hotspots. So, if it's possible, we can enlist all the camps that we have, if it's possible. Because if I'm
Mental camps.
if you put another is talking about the camp, and Najem is talking about the camp, meaning these camps are hotspots for us. You can think about it. So,
Now you have listed, you have captured the ones here. Now the next sub-count.
So, let us first finish where you go, then you go to Mukono, because those are the two facilities that we have captured. So, in this sub-county C, we go to
What is that sub-count again?
C. Double SI. Yes, where they eat, live and they eat. So, I've talked to the chief person there. There's main district, Namukuma Parish. Namukuma Parish. This one is a new learning site and it's a training center that have a lot of blankos. So,
Is it the one covering the same?
Yes. The reason is that during cast goes so many.
There's a learning site.
So another parish to Zitwe is also a near learning site. But also one I don't know, St. Town Council, which is the biggest learning site there. Those three sub parishes. The villages, she didn't give me because she was doing art clinic. Then
Ngobwe.
there is a Ngogwe. I've not got the parish exactly, but Ngogwe and C, they are nearby and they are sharing that Namukuma parish. Because in this quarter that I've seen that they had around 16 patients in this high school. So now, which parish is near neighboring Namukuma? In Ngogwe. Near Mukono. Okay, it's fine. We shall, this is like it's on. We shall ask from the chief council from Buikwe, and I will share with you. Town council.
Around there, yes.
So, town council is the biggest service that we have, and there's a facility called Makongi there. And they have a lot of TB patients and they come from that area. Reason being, the fishing area and it's congested. They have only 4 parishes. And it's just a small town. So we can take it for other hospitals.
But it's not a catchment area.
It's not a catchment area for all, but
And it was an MPS also first capture the catchment areas.
and now we're going to Mukono because of this. Yes. So, Mukono tell us, we can really tell you. And now,
Kokonjero, I think we take it as a town because it is part.
Okay. Yes.
And
Dr.
that's
One.
properly labeled. We have handled this. This is Nigerian. This one here is Nigerian. This one is in Ngokwe, we have handled. This is in Kokonje Town Council. This is Buikwe Town, Buikwe sub-county. And this is Kaolo sub-county. Okay? I think this is Nagoje. And this is what? Nama, yes. So this is the one which is being left out. The one you were completely. So let's handle. Kokonje, I think we shall take it as a town, because it is one small place. So Kokonje will go as a town. Then
It's a town council.
yes. So when you go sub-county, what have we decided for? Not what's sub-county. No, you talk of the town council.
No, I think because of how it's under cover, because we're getting
Why?
Yes.
So
I mean, it's
why should be the Kaolo sub this one division, this one here. The Kaolo division. So Luwaya is in Kaolo. So it is the hotspot for Kaolo.
Kaolo, Walo.
Luwaya,
Why is
the hotspot.
It is
And then Butini, yes. Butini near Butini, I think takes Chitega. Yes, and there is also a train, what? Yes, factory. So Butini and what and the way for Kaolo. Okay. So Nigeria we handled. How about Lugazi County Council? So we take it as a whole. Lugazi Central Division rather. Yes. And the Gere started. Yes.
They are there, yes.
Yes.
Outside, slums, there's slum areas. Then we have Flamingo what? Has also its villages. And we have now, not so much as a hotspot. But like after that, and Flamingo, we have so many different districts.
and they have camps.
Okay. Yes.
So we are taking a look at this division at the whole.
Okay.
By conclusion.
Yes. So I think is this Nigeria? It looks small. I think this was the county council. So now we can go for language. Which are the hotspots in language? Mukono, this one.
Well, in Nagoje, I think we should consider almost all functions because we also
How many are there?
we have 8 projects.
Can you mention them?
And there are those who seek solutions. They have multiplications and others. This could either
And they have many camps.
We
Mental
have
camps.
camps
eh,
and we did conduct tracing, but
the border tracing what did this show you?
we did get
This is the positives.
the distribution of our missions was more parishes, except one.
So now we did
So you might-
So you remain with 7 parishes. So you mentioned them. So what is your mentioning? Namagunga, Namagunga Annex, Namatarate, Namatarati, Nachivano, Nagoji Parish, and Charbia. Those are 7. So can we go? I think they have been captured.
Doctor, the Kaolo team tell us that they are exposed. And that's what they are giving.
So Wagara should be in. That is your argument. So Wagara should also be included. So now we can go to Nama.
Nama.
Maybe,
Yes.
let's go to Nama, but then I want to say, remember, there are some of the parishes where you find people are, it's like a village, people school, and you don't get a case like that. But there are also those where a lot of people congested together, and other things, and those people focus on them. But as we said, you can focus on a few where you think you can hear a lot now. Next time you say here, we never ended much. Which other ones can we focus on that?
So Nama is going to
What's the next one? Now, which other ones? We're going
to Nama. From Nama.
Nama is Nama.
Nama Ojolo. There is another market there.
There is another one there where you pass the road.
Yes. Walusubi, Nama Ojolo. Then
Yeah, but then which is okay, you name them. Which is on IPB? Or deciding on yeah. From all those places. Namadura Parish. Atogo Parish. Atogo Parish is the training center. Asenge Parish. Fatima is where? Amuli Parish. Fatima. This is the university.
the parishes. Okay.
Which one is clear for the category of QC? This one? This one?
And the one down is Satan Naziko.
No.
Up. There you. Your boost. Your boost. There you.
That one. That one is next to.
That's the sort of, are we talking about that? Let's talk about the first one.
Nobody was in
But I think you are still people who pass it. Yeah, you can tell us about that. You are wondering from that one. You know that.
we can move
So she will call and give the information.
Okay. So somehow, I would say that we've sort of generated the list.
Excuse me. The list should include TE in the land site, though it is not labeled there. Since C was handled, TE in the landing site, since it is actually between the two districts of Buikwe and Bugoma, should be captured. And it is the town council now. Let's take it.
In the town council.
Yes.
Let's now go to the next phase. I want to show you also based on the data. We have had a discussion based on the reasons we have listed somehow. And based on the data, also when we looked at the records, what were the most? As I told you, the data we use sometimes the past and other reasons. That's why it's good to brainstorm after those other steps. So I want to as you said about the catchment area, that was the catchment area for what we saw earlier, Kaoro. And these are the ones that have been, we've identified hotspots within this area and people. And these are the details of some of those parishes. You may not be seeing that most of these are parishes. Based on the data from the TB registers and the notification, we went further, and before even looking at the TB notification, there is an index. You know, TB is also a poverty-related disease. And look at that index, which is generated with a map of indicators, show which of these areas there will be more poverty and other things, and that can also relate to where TB may be. And that's based on data. So this is the micro poverty index by parish. So these are like, if you look at the distribution of
Poverty.
the parishes, yeah, as per those parishes. I don't know whether that reflects what people might think, but this is based on data that may not necessarily. And that's how it is reflected. Being red, being lower than others. And finally, when we looked at the TB notification by parish, this is what we look at. These are the TB notification by parish. The highest in the red, yeah? The highest parishes. These are the parishes high in the red, are the parishes with highest TB notification. Based on the records, but remember, this does not capture what is in cast, and in cast you capture more. So these are the parishes. If you look at these parishes along and say from up, which are the parishes from the top here, I want to read them to why we came from up here. To see if you are selected, this is the order in terms of based on TB notification, but we are brainstorming based also on other factors.
So many parishes.
The first representation of the community that can be the parishes. There is the first parish, TB rate, the highest TB rate, if you look at the parish, is Katogo. which is Katogo based on the TB notification. You see? Then there is Nagoje. Nagoje, you know Nagoje. Parish. There is Buikwe
Buikwe. Down this word here.
About it.
Yes.
There is Nabaojoro.
Yes, it was mentioned.
There is Sagas.
It was not mentioned. It is Kawolo. Yes.
Sagazi.
Yes.
Then there is Kisigo.
It was mentioned in that gem.
Like it was mentioned there. There is Buora. Buora is Kadebe. There is Kiteza.
Kiteza Kawolo.
There is Utinini.
It was mentioned. Kitega. Lucas. Yeah, Kawolo.
There is Burika. Burika. There is Bibo.
Kawolo.
Wagara. Wagara. There is Sacha.
That gem. It was mentioned.
And there is Nakibano.
Kawolo.
That's good.
Now, if we look at the parishes, like those parishes mentioned, there are those which we have mentioned, there are those you mentioned. A number of them relate to each other.
Yes.
And we need to agree if we can look at people who are 15 years and above. If we are to have, so let's assume we have 20,000 people who are 15 years and above. We can add the total population within those parishes. And we want to screen maybe 10,000, or a bit more than 10, 12. Because we want by the end of the 4 months to have screened about 12 or 15,000 people. And we are now looking at the population. If we are to take, on average, do you think how many people are in the population in the parish who are 15 years and above? In the parish, how many people who may be in the parish? Remove the children. You know 50% of our children, 15 years and below. Yeah, so we are just concluding, just a minute, to just conclude so that we can have our other discipline. But we are saying, what do you think might be the population? 2,000 people per parish may be 15 years and above. 2,000. Looking at the population. Of course, it may vary, but on average, because if we are to say we select 10 or 15, yes.
You know, some countries, for example, in Drama, are highly populated.
I agree.
And others are, of course, less populated. On average, if they are in Drama, you find that at least they are not 10,000.
In one parish.
Yes.
In one parish. You may be 15 years and above. So,
and for that, Katogo parish in particular, you know, Katogo as a facility is in the extreme end, actually on the border of the Nagoje. So I'm not surprised that the numbers are high, since near the Nagoje got the over 40 just so they must be having something in common.
So now, if you think, now we've listed, we talked about more than 10 parishes, and they are scattered in different areas.
But you see, Katogo Parish is bordering in Abuja. So I'm not surprised that Katogo is leading since also over 40% in CHTB. So I think there is something in common they share.
So can we maybe come up with a quick list? Yeah? Should I read and say the ones you wrote up and say which one do we add in and others? And say, then you can maybe say, this time we take say 10 parishes where we focus. It does not mean the people in the neighboring parish may not school here, but we are using this as a focus, as hotspots. But even when you are moving in this parish, if you move here, you can be at the border of the parish, the people here next door can come into the school. But we are focusing in these parishes. Next time when we come, we can say now let's focus in these other parishes, for example. So if I read these parishes, yeah, let's see of these parishes, which parishes should we read? Now we have, do we all agree on Katogo?
Yes.
Yeah? And Nagoje? Those we, from the data we showed, we have the highest notification. There is Buikwe A.
Yes.
Yeah? Do we agree on Namaojoro?
Namaojoro has actually the slums and the ghettos inside.
If you think we should agree that it's a guy. Do we agree on Sagas? Sagas? Yeah? Yes. Do we agree on Kiziko?
Yes.
Yafka. Do we agree on Mola?
Yes.
Do we agree on Iteza? Do we agree on Kutinimbu? Which other parishes do you think that, based on either caste or others, we should be including those that I have read? So, and those two, East and Buikwe and C, are not part of the catchment area for Kamu.
Yes.
So we are focused on this and also doing those.
Yes.
Kasenge Parish, first of all, it has very many factories. Secondly, it has some camps up there. Actually, even during CHTB, we didn't manage to do some of the villages because given the distance and also the time, I suggest, though there is no support in that, but very, very highly initiated.
But if you don't get cases here, you don't have in the casting, you don't get cases, you don't have notification, probably.
No, we've seen the number of these patients from those areas. According to our data, we get the number of cases from Kasenge Parish.
So you may be there, but may be lower in terms of notification rate. Here we have some of the sites where there was no notification rate. Buikwe from the data, Buikwe B, Buikwe C, Bukasa, Kasaba Kaboa, Kate, all those had zero based on the data. Yeah? So in a way, let's agree to take this. Yes. Buku. Now in Natebe, which one have we?
In Natebe, we have Sacha, Wola, and Chisibo. But we also have Munya.
Among those we mentioned, which one was from there?
Sacha, Wola, and Chisibo.
Sacha is there. Wola. Kizigo is there. We mentioned Kizigo.
Yeah, but Munya is there, and most of the camps.
Okay, now what might happen when the team comes to Kizigo? Eh? How far is Mvunya from Kizigo? So that one, that's why we say these boundaries may not, because if we come to this area and we are camping here, you see we camp next there and there, we can end up all those people from the neighboring place coming in. So it will not be good to name this one and the next one and leave the other one. Yeah?
So, members,
we are going to.
we are still not meeting.
Let's see. We have agreed on somehow with this. We are going to finalize the list, share it with the DHO and the team to know which will be this final, where we shall finally start. We are going to have this meeting probably closed, but after closing, I can see the lunch is also ready. But we also want to demonstrate how our system works. And those who even need to take an X-ray, they can take an X-ray, but it needs a bit of privacy because we have a room or something, because these buttons, you have to remove the shirt and remain under shirt or something, so we need a bit of privacy. And also gender sensitive, we have ladies, so in case the ladies have to take the X-ray, sometimes some people may remain in the clothes. If it's a t-shirt and they may be not nothing which may create anything, they may remain in them. But we shall do that maybe after lunch, and they can give us a small private room where people can be able to be there and they take that X-ray. So with that, maybe I will stop for now. I want to thank you so much for giving the time and going through this. I think before that, maybe on behalf of my team, I think people have registered their numbers. Shortly before probably we move here, there will be some little transport refund for the people, which should come on those numbers which is registered on the phone, maybe before we finish to work on that. So now I hand over back to that guy to invite
So we first clap for you mentioned of the transport. How many miles or kilometers are we receiving now? Because
at least there should be a minimum of 50.
Minimum, maximum of 100.
Now what about first from Bono?
First what happened?
A minimum of 50.
Good. So maximum of kilometer 10, minimum of kilometer. Good. So come for me. So let us invite our dear RDC to give us a closing remarks. Maybe a bit of background to this meeting. So this is the CHASE TB project that has selected Buikwe to develop and identify TB cases and also to improve treatment outcomes. So it's here for work in the community and facility. So these are in charges, typical persons, Mokono and Buikwe. We have MS Kaolo, we have a DHO has been here, and me, myself, and others. We have a team from Kampala, those teachers, CHASE TB, and Dr. Ash is the team lead. Thank you.
Ladies and gentlemen, I'm not going to take a lot of your time because you have been here since morning, but also discussing the productive information that help our nation move forward. I came in late, so protocol may not be really very good, but I'm glad the in charge of Kaudon Hospital is here, who is very active civil servant so far I've ever seen for many years. You should understand that TB has been here 5,000 years. Actually, when you look in the Bible, the book of Deuteronomy, Hebrews, even TB was there. What is important as leaders, as health workers, we must first of all focus on the risk factors of TB. One of the risk factors is poverty. It is poverty. That's why as government, as NRM government I serve, our focus is on how do we transform our societies economically. Because when we transform our societies economically, they will empower themselves. Then there is another problem of stigma. You know very well, sometimes TB is a sister to HIV, or brother. Once a community identifies a person who was HIV or was TB, they will shy out from that person. Hey, this one has TB, this one has TB. Even though the person is free from HIV. So as health workers and other leaders, stigma is very important when we are fighting TB. I was looking at the TB dashboard when I received your invitation, where it says in Uganda on a daily basis, 223 people get infected with TB and 30 deaths. This is still a very big challenge. If a country we can have 223 people being infected with TB. But then we can fight TB when you are here to support us as a district, as a region. So if we get serious, we can have our community free of TB. This madam discussed a very important point. We must secure our health workers first. Remember during COVID-19, government had no capacity to provide protective gears to health workers. And this was one of the biggest challenges in fighting COVID-19. Because the health workers themselves would fear to handle people. Because you also need your life. In the military, we don't have life in plural. Life is in singular. It is in with one inch here where you find life is in plural. Somebody can say, okay, you can't kill me. Somebody is with a panda, okay. Somebody with a gun has started it, okay, kill, okay, shoot. In the military, they will tell you life is in singular. So life must be protected. I was here, and then the other point of Mansos came in. I hope the DHO has taken this very important. We have a new cow and a very senior cow, Dansan Balaba, who is, I've also worked with Dansan Balaba in Jinja. We have a very strong manager here, Dr. Chiveru. I think he will be able to address the challenge of human resource in line with what we are discussing today. Because it will be a very big challenge if people are ready for screening and the machines of human resource are lacking. Then I saw you talking about the screening pregnant mothers, where you said 1 month, 3 months, it is still forming, but maybe if it is 7 or 8, we should be able, I think, to handle. Because, you know, we have teenager pregnancy, which is a very big problem in our country today. Somebody is P5, P3, but is pregnant. P6, P7 is pregnant, and the mother is very happy. They even invite them to come and bring sukari to give away the to give away the daughter. Mm? These are one of the biggest challenges. We should also, you see, still, when you look at Europe or North America during the 18th and 19th century, because that was the National Revolution, this was also a very big factor. But when you look at, although we're in the 21st century, but the Industrial Revolution in our country is just taking off. The pollution is too much. It is a big problem. And this can cause it. And you know, most of our people, because of unemployment, are running to factories. And the so-called investors, sometimes when you tell them to do ABCD, they will tell you, no, we shall call the president. And they are telling you lies. Put what is supposed to be put in place so that you can save the lives of the people.